Alrighty, so here we go with chapter 34 in our pediatric nursing care. We're going to be going over the child with GI conditions. Alrighty. So our pediatric gastrointestinal system, it's responsible for our digestion, our nutrient absorption, fluid and electrolyte balance, waste elimination, can help with our immune defense and supporting just normal growth and development in children. Our GI conditions are common in children. The GI conditions that are common in children are primarily caused by infectious agents, whether that's bacterial, viral, or from parasites. It can be from congenital abnormalities. It can also be acquired conditions. So one of our most frequently seen pediatric GI conditions is gastroenteritis. So with this is what we learned is an inflammatory process affecting the stomach, the small intestine, large intestine, and is most often caused by viruses. Common manifestations of gastroenteritis are going to be nausea and vomiting, anorexia, abdominal distension, abdominal pain, and diarrhea. Children are going to be particularly vulnerable to dehydration just due to their smaller fluid reserves, their higher metabolic demands, and just their limit inability to communicate their symptoms. So in infancy, the GI tract, it's immature and it's going to continue to develop after birth. In newborns, they're born with a sterile GI system. Normal intestinal bacteria are gradually going to be introduced through feeding and then environmental exposure. This is going to be essential for their digestion and immune system development. So at birth, our infant's stomach is going to be quite small. The capacity is going to be about 15 to 20 milliliters. They have a rapid growth that occurs in the first few weeks of life, with the stomach capacity increasing to about 90 milliliters by the second week of life. And this allows for just the greater feeding volumes as the GI tract matures. Alrighty, so we'll talk a little bit about obtaining a health history in children. So when we're doing an evaluation, we want to ask the parents about the child's food habits, having that include their dietary intake, what kind of pattern do they have with eating, do they have any feeding difficulties, whether this is in an infant or a school-age child, are they having any issues like dental issues that are causing trouble for them. So we want to just try to address any feeding difficulties that we could have. Their elimination habits and patterns should also be assessed. So we want to ask about stool frequency, the consistency of their stool, and if they've had any changes from their baseline. We also want to try to identify, are there any problems in this step from digestion to elimination that we can put our finger on. So whenever we get to the past medical history, we want to go through any previous gastrointestinal conditions, any surgeries, allergies, any chronic illnesses that can contribute. Alrighty, so whenever we're doing a focused GI assessment, we want to have a measurement of weight and height to evaluate their growth trends, along with assessing their bowel elimination routine. Once again, the characteristics, and then the time of their last bowel movement. Hydration status, we want to assess by looking at their mouth, looking at their mucosal integrity, their hydration, inspecting the abdomen, looking at the contour of it. Does it have any distension? Are there any visible abnormalities that we can see? We want to auscultate their bowel sounds. And then whenever, remembering that we want to auscultate before we do any palpation and percussion. We want to look at their laboratory results, if there are any diagnostic testing ordered, anything to help us guide our further evaluation. Okay, so we have a little clicker check here. During a home visit, the mother of a 2-week-old infant is upset when the child will not drink an entire bottle when feeding. What should the nurse emphasize with this mother? Okay, so we want to make sure that we teach this mom about the size, their stomach capacity when they're first born. So we know when they're first born, they're about 15 to 20 milliliters, and then by the end of the 2nd week, we're about 90 milliliters. So I would on here choose A. The stomach capacity is on here it says 3 ounces. Remember, 1 ounce is 30 milliliters. So with that 3 ounces, we're around that 90 milliliter mark. I don't know if I said milliliter in the first one, but that's what I mean, not millimeter, milliliter. Okay. Alrighty, so next we'll talk about vomiting in children, also called emesis. So emesis is a reflex action controlled by the emetic center of our medulla. When evaluating vomiting in children, it's important to differentiate between true vomiting and then just like benign regurgitation. So we have a lot of like the wet burps in our infants. We want to assess the frequency, the consistency of these episodes. Was there anything precipitating the vomiting episode? When we talk with the parents, we want to ask about how would they describe the consistency of the vomit, any characteristics, what color, is it mostly watery, is it more solid, and if we are seeing anything accompanying the vomiting, any fever, diarrhea, headaches. So we want to ask about the fever, diarrhea, and headaches just so we can help evaluate if there's any infectious, neurological, or systemic cause behind the vomiting episode. So during evaluation, we want to observe and inspect our child's abdomen, looking for distension, tenderness, do we see any masses, and then measure their abdominal girth. We want to assess their nutritional status using that height and weight that we gathered, looking at their overall growth pattern. For our infants, we want to ask about feeding positioning, ask the parent to demonstrate how they're holding the child. Do they have improper positioning that would put the child at risk of an increase for reflux and vomiting? We want to talk to the parent about any electrolyte imbalances that they could have, try to educate them with the dehydration and how we're going to help correct that. We want to check the child's psychological status. So does the child seem to be experiencing a lot of anxiety? Then if age appropriate, we want to bring up this self-induced vomiting and rumination as well. You want to talk to the parent about if they're having any episodes of projectile vomiting. So we're just going to assist in ruling out any other conditions by taking that thorough history and then speaking with either the RN or the provider that we are working with that day. So next, the interventions that we're going to do. Firstly, we're going to put that child, make them NPO and communicate that with the rest of our team. So the child will have nothing by mouth. We want to educate the parent what that means, why we're doing it. We want to place the child in an upright position or a side-lying position to help maintain a patent airway. Going along with our airway, we want to ensure that we have the presence of suction. For any patient that has a decreased level of consciousness, you want to make sure that you have that suction available and ready. When we do decide to start to introduce fluids, we're going to start with clear liquids, giving those slowly, and then progress with the diet as tolerated. We may want to withhold some oral medications if we have another route that we can give them that's preferred, whether giving them rectally or parentally by the IV. So we want to make sure that we have our child on I's and O's, so recording their intake and output, educating the parent on what this means. So having them tell you, oh, they drank, half of this juice, we had a wet diaper, and having them, save the wet diapers so that they're able to be weighed. We do want to talk to the parents about good oral hygiene during the vomiting episodes, and then also use any antiemetics that we can to help prevent nausea and vomiting that would be interfering with our hydration status. So for our nursing considerations, we are going to be monitoring for dehydration, aspiration, sore throat, and also weight loss. So moving to gastroesophageal reflux, this is going to be a condition that's caused by a poorly developed or incompetent cardiac sphincter. Another name for the cardiac sphincter is the lower esophageal sphincter. So with that decreased muscle tone, they're going to be at an increased risk for this reflux, just because it's allowing those gastric contents to flow back up into the esophagus, and that can also contribute to ongoing vomiting and feeding difficulties. So with diagnosing, we're going to evaluate any gastroesophageal reflux behaviors, asking the parent if they're having any of these, such as spitting up after eating, irritability, kind of doing that arching their back. We want to evaluate the onset in relation to the child's positioning. Are they doing this during a certain time of eating? So whether, they're supine prone, if it's, 15 minutes after feeding, when are they displaying certain behaviors? So we're going to want to check the gastric pH to confirm that this is an acid reflux. We want to assess their weight and look for any failure to thrive in these infants. We also want to evaluate if there's any chest discomfort or pain cue behaviors, such like the crying, refusal to feed, or once again arching their back like that. So this is going to become a priority problem for you whenever you do have that interference with nutrition, growth, and then airway safety. So we want to prioritize our non-pharmacological interventions. So we want to encourage parents to have their child in an upright position while feeding, provide the small frequent meals, feeding slowly, assessing the child's tolerance during the feed. We want to talk with our formula-fed infants if they would benefit from a thickened formula, so working with the nutritionist to see if that would be beneficial. We want to encourage parents to burp frequently, burp their infant frequently during the feedings. Our medications, we want to try to maximize our non-pharmacological interventions before moving to medications. We're going to try to reserve those for our children that are having complications such as the failure to thrive, any respiratory issues, if they're experiencing some esophagitis. So when it comes to parent teaching, we really want to emphasize, the small meals and feeding them upright. If I was going to ask about this on a test, your priority teaching for the parent, it's going to be something non-pharmacological. Okay, we're not going to move straight to the medications until this infant's having more of a complication. So then we want to try to identify this gastroesophageal reflux early by noticing, recognizing the patterns of feeding intolerance, irritability, poor weight gain, the presence of respiratory symptoms. We want to try to differentiate this against infant colic, infection, or any respiratory conditions. We want to, so differentiating from that other pain. We want to maximize our non-pharmacological interventions first, and then if needed, move on to pharmacological, So our non-pharmacological interventions, again, we're going to teach the parent about positioning, feeding modifications, so smaller, more frequent meals. Yeah. So diarrhea in children can be caused by infections, allergies, a toxin exposure, or just malabsorption. Our nursing evaluation needs to focus on the amount and the duration of stool loss. So we want to try to have an accurate intake and output, assess for fluid and electrolyte balance, be observing the stool by color, consistency, if there appears to be presence of blood. Daily weights can help us monitor a child's hydration status. So the nurse wants to try to develop a relationship between any feedings and symptoms. So try to match things up and see if certain things align. We want to evaluate our child for pain and cramping. Sorry, I kind of skipped around. And then also we want to check the skin integrity around the child's anus to help prevent skin breakdown. So continuing on with this evaluation of diarrhea, we want to auscultate the child's abdomen, listening for their bowel sounds. We would expect with the diarrhea for them to be hyperactive. We can palpate the abdomen, see if they're more tender in certain spots. We want to be checking for fever. Is there any reason to believe it's an infectious cause? So we want our nursing focus to support hydration and gut recovery. So how we're going to do that is we're initially going to place the child in an NPO status if we still have vomiting, or if we have vomiting present. And then we'll begin to orally rehydrate our child, avoiding fruit juices just due to the high sugar content, which can make our diarrhea worse. And then slowly we'll start to introduce foods, being careful to choose age appropriate. We also want to encourage a well-balanced diet. So additional nursing interventions for pediatric diarrhea, you may administer antidiarrheals, antiprotozoals, or antibiotics based on the cause. So it's important to explain to your family that we can't just, pop this kid an Imodium before all of, their stool is tested. And those things do sometimes take a few days to come back. We want to make sure that we're not routinely giving these antidiarrheals with infectious caused diarrhea, just because that can prolong our infection, especially whenever there is fever accompanying it. The antiprotozoals, that's going to be for parasitic infections. So think of something like your daycare type of diarrheal causes, and then antibiotic, of course, for the bacterial caused diarrhea. We want to make sure that we're trying to take care of the skin and the diaper area very meticulously, applying any topical ointments if needed. And then usually upon the child coming in with diarrhea, you're going to use those contact precautions. And then if you are suspecting that it is C. diff, you will have them in enteric precautions. And remember, with our enteric precautions, we're not using our hand sanitizer, we are soap and water washing our hands. So we want to prioritize our hydration and our child, looking at skin integrity, and then also infection control. So one thing that we do want to recognize is that we can have some foodborne illnesses such as salmonella, and that can just range from your mild GI distress to a severe life-threatening infection. So on the other spectrum of things, we have pediatric constipation. So in kids, we understand constipation as being fewer than 3 bowel movements per week. These kids are going to have that stool being very hard, dry. It can be large, difficult to pass. They can have a lot of abdominal pain with it. They may experience some blood on the outer surface of the stool. There may be traces of liquid stool in the child's underwear that could kind of lead you to believe that there's some impaction. So acute constipation is often going to be associated with just a diet low in liquids. If we have chronic constipation, that could be from our persistent poor fluid intake, decreased physical activity, and then just low dietary fiber intake, just overall poor nutrition. So in an evaluation, you want to talk with the parent about frequency of stools, how often are they going and about how much is actually getting excreted. We can perform the Goyak test, so that's going to be like your occult blood sample. We may measure our patient's abdominal girth daily. We want to determine if our patient is having any pain, so is this pain from irritation and skin breakdown? Is this pain just from the hardness of the stool and like true rectal pain? Is the child experiencing fissures? And we can also determine some of those things by inspecting the perirectal area. When it comes to a child having stool withholding behaviors, I kind of call this like whenever a kid stops and freezes while they're playing and they're like, they can't, they'll kind of like stiffen up and kind of go with a rigid back. So just kind of things where the child is cueing that they need to have a bowel movement, but they're too busy to deal with that. Okay. We also want to educate the patient and family about increasing fluid and fiber intake, trying to have that regular toileting routine. Okay. And then we also want to promote plenty of physical activity if possible to help promote healthy bowel movements in these kids. So interventions that we can talk about with the parent is creating a consistent toileting routine. They can try to take advantage of that gastrocolic reflex after eating meals and having the child, shortly after a large meal sitting on the toilet. There can be medications such as like stool softeners and laxatives that are given. I feel like with the pediatric population, we see a lot of Miralax that'll be given. Placing lubrication just over the anal area before experiencing a bowel movement. If needed, if the child's impacted, digitally removing the stool if necessary. We can encourage like a squatting position. Now I feel like those little like squatty potties are becoming more common, but teaching the parent to kind of bring the child's feet up some so that they're in more of a squatting position by using like the little stool that they may climb up to get onto the big, like the little step stool to get up on the big stool. And just that positioning makes it easier to pass the stool. So in coparesis, this is going to be an obstructive condition whenever the retained stool kind of leads to a leakage of stool. So you have this hard, like impacted stool, and then you have liquid stool leaking around it. So it's important to know with this that it is not diarrhea. This is a sign of chronic constipation with fecal impaction. Okay, so sometimes I've not personally seen this with a child, but a lot of like your belly surgery patients, after if they've experienced an ileus after, and then it's been, I don't know, we'll say 6 days since they've had a bowel movement, they may, a nurse may report that they had some loose stool, but are they truly passing all their stool? So that's kind of what that is. So we need to focus on having the whole stool removed. So next we move to cleft lip and cleft palate. You have a picture of how this appears on page 606 in your maternity and pediatric book. But these children are at a higher risk for aspiration, poor nutritional intake, and increased infections just due to that impaired sucking and swallowing mechanism. So we want our assessment to focus on identifying any respiratory distress during feedings, the effectiveness of their suck-swallow coordination, and then monitoring for any abdominal distension during feedings. This can cause some infant-parent bonding issues and just requires a lot of support and ongoing education and reassurance for parents. Jeez, I can't talk. So for these kids, we can intervene with surgery to help close their palate, to reconstruct things. Okay. So preoperatively, we want to focus on adjusting the feedings to improve their nutrition. We want to use sterile water to help reduce bacterial growth, like when mixing formula and things. We want to use a very supportive approach with the family, just making sure that we're putting them in touch with resources. There's a lot of like support and social groups just to help lean around the family and connecting parents to say, this is what worked best for us pre-surgery. Those are just a really great resource for parents post-operatively for these kids. We want to maintain a clear airway. Anytime we're having something done in that area, we want to focus on maintaining that patent airway. So priority, we want to have that upright positioning or side lying positioning. We want to monitor for any infections. We'll probably still be using that sterile water afterwards, treating for pain, preventing any trauma to the suture line. So adjusting maybe like the nipple to the bottle if needed, just so that child can have the most efficient suck swallow. And then we want to clean that suture line carefully. So prior to surgery, we want to evaluate this family's competency of care. We want to make sure that they have the understanding that this is likely going to be done in several stages, that this repair, it's going to not just be fixed with one surgery, it's going to be coming back and, doing things kind of in stair steps. So we want to make sure that they're going to be in this for the long term to give their child the best chance at success. Also using this ESSR technique, so using an enlarged nipple, stimulating the sucking, watching for the swallow response, and then allowing the infant to have multiple rest periods. That's going to help prevent our aspiration. Okay, so next we have esophageal atresia. That's where we have an abnormal termination of the esophagus. Okay, so this is often going to be associated with a tracheoesophageal fistula. We diagnose these by looking for the presence of excessive oral secretions, coughing, choking, any signs of respiratory distress, especially during feeding, intermittent cyanosis, and then tracheal irritation from that gastric acid. So we just kind of, our esophagus isn't terminating in the stomach. We have kind of a little runner going from our esophagus to our trachea. So that's what we're looking at here. So interventions that we are going to do for this, we're going to maintain an NPO status until we can have a PEG tube placed for this child. We're going to orally suction them frequently. We're going to prepare the child and the family for surgery, which is going to be the definitive treatment for this. If we suspect esophageal atresia, we really don't want to orally feed them, even small amounts. Okay, we are going to want, so your book says very small amounts of liquids, but if I was going, let me see how I want to word this. For safety reasons, I feel like an NCLEX question would lead you more towards keeping the patient NPO, okay? Because we have other ways of giving an infant nutrition already. So I would always go for the NPO. Okay. So a tracheoesophageal fistula, that's going to be an abnormal opening. So by diagnosing this, we're going to be looking for choking, coughing, intermittent cyanosis, abdominal distension from the air entering through the stomach, through the trachea. We're going to be looking for respiratory irritation from gastric contents. Recurrent pneumonia and aspiration may be present as well. So here we're also going to intervene by maintaining an NPO status to ensure that we have that patent airway. We want to position our head upright, have our suction ready. Okay, and then prepare our patient and their family for the surgery to reconstruct the trachea and esophagus. These are considered like emergent situations. So your priority nursing actions for these are going to be the NPO, airway protection, suction. Okay, you're not going to prioritize things like nutrition at this point. Okay, you want to think of your more emergent things. Yes, we want to worry about nutrition at some point, but is it our priority? Okay, so think about that with questions about these. So for the tracheoesophageal fistula and then the esophageal atresia, they can kind of look similar in certain ways. So a little like way to remember is air in the belly, milk in the lungs. You have the TEF. Okay, so the transesophageal fistula. Whenever you have just like excessive drooling, which you can have with both, but if you are unable to like place an NG tube because that esophageal atresia, that's terminating at the wrong spot. Okay, so you're not going to be able to drop an NG. So that would be your clue that things aren't anatomically correct. Okay, so you're going to think just the esophageal atresia, associating that with the inability to place the tube, and then the big distended belly, that's going to be more of your transesophageal fistula. I don't know if that muddled it or made it a little more clear, but educating and supporting the parents, having their expectation for their child to be on tube feedings until this is healed is important. Okay, next we're going to talk about pyloric. So this is where we have hypertrophy of the muscle surrounding our pyloric valve. Okay, so this is going to be causing an obstruction of gastric emptying into our duodenum. This is going to most commonly be in our infants around 2 to 8 weeks. It's more common in males. So we're just having that progressive narrowing from that hypertrophy. And then our stomach can't empty from it. So our hallmark symptom we're going to have of this is the progressive worsening of projectile vomiting. The child may also have like a palpable olive-shaped mass. We want to look for signs of dehydration. After having these projectile vomiting episodes, the child can often appear hungry after the vomiting episode. Ways that we want to intervene is placing our child in NPO status, positioning them on their right side to prevent aspiration, placing an NG tube, and then correcting any electrolyte balances, and then introducing clear liquids when we can. Okay, before that we'll just use our IV fluids. So we want to keep in mind that our child with pyloric stenosis, they can come in similar to a child with failure to thrive in dehydration. So next up we have Hirschsprung disease. So this is going to be a congenital aglionic megacolon. That basically means they have this absence of ganglion cells in the distal colon. So there's going to be no peristalsis to help that segment. Okay, so without these ganglion cells, the bowel cannot relax there, so it just starts to back up and back up. This is usually diagnosed during early infancy. There's a failure for the newborn to pass the meconium stool, and that just gets compounded by the chronic constipation as well. So during this, the infant can have a gradual onset of vomiting, and they a lot of times will have this abdominal distension. They usually will have kind of alternating chronic constipation and diarrhea, but a lot of times they just look uncomfortably distended. So with this, they can have issues with nutrition because of that loss of appetite and just the reluctance to take anything in because they're so uncomfortably full. This can also lead to fatigue. So when we're talking to our parent, we want to talk them through, like, what is their stooling pattern? What's it look like? Are they having these back and forth periods of diarrhea and constipation? Okay. So, sorry, on the last slide, I can't really go back while I'm recording, but on the last slide, it talked about preparing the family for surgery. So they can go in and take out the segment of colon that is without these cells and just kind of, take it out, go back together, and then hopefully they'll be good as new. So more interventions, we want to monitor for edema, bleeding, any unusual drainage, fevers. We want to keep in mind their skin integrity from this, alternating constipation and diarrhea. So providing good skin care, antibiotics if needed. We want to be mindful of their pain control, educating the family, and reintroducing feeding slowly. So we're monitoring for the infant's tolerance of what they're taking in. We want to be mindful of looking for signs of dehydration in these kids, so monitoring for electrolyte imbalances as well. Okay. So next we have, I'm going to struggle with it, intussusception. So this is an acute GI emergency where one segment of the bowel is going to be telescoping into another. So that leads to a bowel obstruction and compromises our blood flow. That's what makes it an emergency. So children with this will typically present with a sudden severe abdominal pain. And this is where they'll pass these called like currant jelly stools. So this red blood tinged stool and then bile stained vomitus. Okay. Interventions we have for this is taking the or performing a barium or water soluble contrast enema. These barium enemas are pretty hard on your bowels. You can have a lot of constipation from taking that barium in. So we want to prepare the child and the family to expect that and to increase their oral intake if possible to help pass that. So things we want to be mindful of. If you see in a test question something saying that they have current jelly stool and some abdominal pain, you'll think of the intussusception. So our priority nursing actions for that, we want to make sure that we make this child NPO, monitor for any signs of bowel perforation, and then we're not doing any, giving the child any enemas, okay? Oh, well, I kind of got ahead of myself there. Okay, so we want to educate and support the family on what to expect with this. And imperforate anus, that is whenever the child is born without an actual anal opening. So we need, we have this inability to pass stool, so we need to go in and surgically create that. So infant should be kept at NPO, and then go in for surgical management and reconstruct. They can do, they can transplant nerve tissue to help support continence in this infant. Okay. Next we have appendicitis. So this is going to be an acute inflammation and infection of the appendix. It's commonly going to present with progressive lower right abdominal pain. We're often going to see an elevated white count. If we do imaging, such as an ultrasound, it'll also show that we have this enlarged and distended appendix. Whenever we have a child complain of like, oh, my belly doesn't hurt anymore, I want to go home, that's kind of your red flag that it could have ruptured. So with inflammatory bowel syndromes, we'll start with ulcerative colitis. So this is going to be an inflammatory bowel syndrome characterized by the chronic, copious, frequent bloody stools. Okay. Usually they experience a lot of relief of the pain after defecation. Your patient can have some pretty significant weight loss. We want to realize that with this, we're going to have some electrolyte imbalances, some anemia from that bloody stool. They can have an increase in estrogen. When your patient is experiencing things like fever, tachycardia, pallor, and fatigue, those are usually considered when they're in a flare. Okay, so those systemic symptoms, we're going to think that they're having a flare, and then our priority nursing action for these people, we want to be looking at that blood loss, monitoring their labs, looking specifically at their electrolytes. Okay, so with this, we can do pharmacological interventions and diet modification to help decrease inflammation. So they may require IV nutrition like TPN, IV steroids to help that inflammation, or if they're not really getting much relief with those things, they can go to surgical management. But what we want to look for is preventing this toxic megacolon. So next on our list we have Crohn's disease and inflammatory bowel syndromes. So this is going to be characterized whenever you have ulcerations along the mucosal lining of the bowel, but it's important to know this can affect any part of the alimentary tract. So what that means, you can get flares of this, or not flares of this, ulcerations from this anywhere from your mouth to your anus. We diagnose this by taking a stool sample and checking it for frank or occult blood. They usually experience a lot of abdominal cramping that can be quite debilitating, weight loss that can get to the point they'll have so much weight loss that they eventually have some growth retardation. So we can intervene with a few pharmacological manners, nutritional support, looking at supplementing vitamins and nutrition, but we also want to help control the inflammation along that GI tract. So a way to remember this is not going to be relief. They're not going to feel relief after defecating with this. That kind of differentiates one, like symptom-wise, between Crohn's and the ulcerative colitis. We want to monitor their nutrition and growth patterns, assess the stool, manage pain, and watch for any development of fistula strictures. Okay. Alrighty, so celiac disease. This is going to be an immune-mediated gluten intolerance. So this is where our child's going to have an inability to tolerate foods that contain products like rye, wheat, oat, and barley glutens. These foods, they are going to damage the intestinal mucosa and lead to like nutritional malabsorption. This is often going to be like they'll experience flare-ups, and like the precipitating event is going to be the ingestion of these foods. So I believe in like intro to GI, we learned about dysteria. So that's that greasy, bulky, malodorous stool. They'll experience that, failure to thrive, anorexia, abdominal pain, and cramping. So management is going to be a lifelong gluten-free diet, and then in the short term, correcting electrolyte disturbances and restoring fluids. So your immediate correction is going to be looking at this person's electrolytes and restoring those, and then the lifelong management is going to be an important intervention you do. However, that's not going to be your priority. Okay. Another important like thing with this is there's like no cheat meals, because that can really kind of cause your kid to kind of like it's not going to be mild. It's not, a little tummy ache. It's, they're crashing. So anytime this is one of those things with a kid whenever you have that staturia that you would kind of keep in mind. So still with the celiac disease, our nursing consideration is, really intense education about diet. So moving on to necrotizing enterocolitis. So this is going to be a pretty serious inflammatory disease of the intestinal tract. We see this a lot with premature and our medically fragile infants. So risk factors would be prematurity, maternal preeclampsia, umbilical catheter use, intrauterine cocaine exposure, any sepsis, and then asphyxia. So this involves some intestinal ischemia, which is we're going to have inflammation with, and then it can possibly lead to necrosis. So with this, we're worried about it progressing to like a bowel perforation. So when we, like if we're suspecting this and on the x-ray of the kid, we would see some peritoneal air, we would be worried about a bowel perforation there. So early recognition is going to be critical. Knowing, a good health history on the mother whenever she comes in can help us a lot to see if we need to, if we need to kind of have it in the back of our mind, hey, things could escalate to this. Alrighty, so our 3 stages of this. Stage 1, we can expect to have fluctuating temperatures in our infant, episodes of hypoglycemia, hemipositive stools, poor perfusion, lethargy, and then recurrent apnea and bradycardia. So it's going to be more of your subtle signs. One thing that I've noticed about a lot of practice questions is that in pediatric populations, they love the recurrent apnea bradycardia. One of your like easy fixes for bradycardia in infants is going to be because of their respiratory status. So, adjusting their airway, their head positioning, so that they're having a more patent airway to take in more air. That usually resolves a lot of bradycardia issues. So stage 1 is going to be your more subtle signs. Stage 2, you're getting to your red flag, like I tried to get your attention before, but now I'm fussing a little more. So you're going to have some pretty severe abdominal distension, grossly bloody stools. You can have absent bowel sounds. And then stage 3, you have septic shock setting in. So you're going to expect your child to have some hypotension, more episodes of the apnea bradycardia. They're going to have pretty significant abdominal distension in this, so we don't want to think abdominal distension and apnea and think of reflux. That apnea is going to be your trigger to think this necrotizing enterocolitis, because if you reach stage 3, you might have the perforation leading to that septic shock. And once kids are very, they can like chug along for a long time and they're very resilient. But once like hypotension sets in with a kid, that's whenever you're getting to, you're at like an oh no stage, you're crashing. So, alrighty, let's go on to the interventions for this. So interventions, we need to expect to have some antibiotics on board for that perforation. Usually we're going to start with the broad spectrum. We're going to have some vascular and then hemodynamic support, IV nutrition, allowing that bowel to rest if needed. In more of your severe cases, when that necrosis and perforation is present, then you'll need the ostomy creation. So this is going to be your, our pediatric PICU patient. Okay. A lot of emotional support and education for the parents. When it comes to your higher levels of care on the NCLEX, they do like for you to have that emotional support for parents. So keep that in mind. But with an infant, whenever you see that abdominal distension, bloody stools, and they're hemodynamically unstable or unstable, whatever, you want to think this necrotizing enterocolitis. Just have that on your radar. Alrighty. So we have our enteral feeding. So when our child's unable to meet their nutritional needs orally, they'll be evaluated. So selecting the feeding approach, whether that's going to be nasogastric, having something more surgically placed, assessing risk factors like aspiration, tube displacement, infection, any intolerance. Our nursing considerations, we really want to make sure that we are teaching our family how to safely administer these feeds. Having, these checklists for them to help promote safety and adequate nutrition for these kiddos. So if the gut works, we want to use it. If it's not able to, that's whenever we're going to go to things like TPN. We want to always have our priority risks with these. So we have our risk for aspiration, incorrect tube placement, feeding intolerance. We want to be sure we're educating the family on always checking the placement before administering any feeds or medications. If they ever are doing these at home and they have new respiratory distress, any coughing, if they're having, if they're, seeing that their child's starting to have oxygen desaturations, then we need to stop the administration of whether it's, the tube feeding or the medications, we need to stop that immediately and assess the placement of the tube. Okay, so caregiver competence and safety are going to be your main teaching points with these. So last little knowledge checkpoint here. We have a kid that's being evaluated for appendicitis. You come in to assess him. He says that the pain stopped and they want to go home. What should the nurse do? We know that this sudden relief of pain is a red flag, so we want to immediately notify our healthcare person, our healthcare provider. Okay. So if you have any questions about this, feel free to email me. I'm going to post something on like the GI section from the study guide that goes along with the book. So if you have any questions about either of those, please reach out. We'll all be stuck at home, so make good use of the time and reach out to us, okay? Have a good one and stay safe and warm.